Okay. All right. Thanks, everyone, and thanks for the invitation. So, as Jeremy said, Sibongile Walaza, I'm the medical epidemiologist based at NICD. So, influenza has been my passion and what I've been working in for quite some time until COVID came. And I think, yeah, so I'm happy to give this presentation to you today. And then as a way of overview, so I thought I'll just give a brief background on influenza, cover the burden overall and also specifically in South Africa, and talk about our influenza seasons and the risk groups for severe influenza, and then cover some information on vaccines and also just a little bit of treatment, and then I'll give a summary. So in terms of burden, on an annual basis, globally, seasonal influenza causes about 1 billion infections and between 3 to 5 million cases. And then we've got about 290,000 to 650 deaths on an annual basis. And we get a lot of illnesses and deaths in children less than 5 years. And the burden has been, it's been reported that the burden is higher in the sub-Saharan Africa. And also, so in terms of the burden, or severity in a particular year, so this will depend. So it varies year by year, and depending on the transmission and of the virus that's transmitting during that year, and also on the host that's being infected by the influenza. And then in terms of the virulence of the strains, this also varies, as you can imagine, when during pandemics, when no one has got any immunity to the circulating strain, you get a high number of deaths. And then even between the pandemics, like if you look at the 1918 pandemic, there were about 50 to 100 million deaths. Whereas in the 2009 pandemic, there are approximately 200,000 deaths. Obviously, the numbers that I'm quoting also depend on how well data is being collected during the period when there's a pandemic. So as I mentioned earlier, that the burden of influenza is mostly in the low middle income countries and also in sub-Saharan countries. So this paper, a systematic review, included 43 studies, and it showed that of the influenza, most of the influenza was mostly in developing countries, about 90% of that, of hospitalization and deaths globally were in developing countries. And there's a number of reasons for that. That could be just in terms of access to care, also the prevalent underlying conditions that the individuals have, that predisposes them to having a severe influenza illness. And again, it's important to mention at this point that even though the burden is highest in low middle income countries, these are the countries that also do not have policies in their countries, for influenza vaccination. So vaccination is not covered as part of treatment, of standard of care or prevention. And then coming closer to home, so in South Africa, so between 20 and 40% of the population is infected each year. And I think as we speak, actually, we've also already starting to get reports that, already children are already missing school because they've got an influenza-like illness. Of course, without testing, you can't say that that's influenza, but if it's during the season, it's more likely to be influenza. And about 56,000 hospitalizations and about 12,000 deaths occur on an annual basis. And about 500 children, less than 5, die each year. And we also did some work looking at in and out of hospital mortality associated with seasonal and pandemic influenza. And this was using, data from your Stats SA and also from death records. And from that, we realized that there's quite a number of patients that actually die in our setting that die outside of hospitals. And when you're looking at the burden, also the burden pyramid, so some of the cases don't really get counted as, so we miss out on those. So from this, so when you're looking at the data, show that influenza accounted for about 4% of all respiratory deaths, and the highest burden was of all-cause mortality was in the elderly, that is those older than 75. And there was increased mortality in children younger than 5 and 20 to 64-year-olds. Okay, so in terms of the presentation, so the incubation period is 1 to 3 days. It took a sudden onset of fever, cough, headache, sore throat, rhinorrhea, and also muscle pains. And the duration is actually quite short, so it's 3 to 5 days. And some individuals may present with diarrhea and abdominal pain. And signs and symptoms also vary with age and underlying illness. For an example, in children, you may have, GIT symptoms more than you get them in adults. So again, influenza illness may not be easily distinguished from other respiratory viral infections. And then in terms of complications, so the complications involve multiple organs, so it's not only restricted to your respiratory tract symptoms. One of the complications would be exacerbation of the chronic conditions like asthma and COPDs, and also individuals who are, I said earlier on, there are about billion infections on an annual basis, but most of the cases will present with mild illness, but then you may have those individuals that then progress to severe disease. So you may get patients who present with a viral pneumonia, and again, this can also trigger a cytokine storm, and then lead to multi-organ failure. And then you can have, on top of the viral pneumonia, can also have a complication of bacterial pneumonias, and then also you get your cardiac involvement, and get things like acute bronchiolitis, and also muscle involvement and CNS involvement. So this is the structure of the influenza virus. So it's been around for quite some time. And so it's a genome composed of 8 RNA strands, and it's got 2 surface proteins that are very important in terms of the response, and also how we then, then we name the viruses based on those proteins. So the predominant surface protein is the hemagglutinin protein, and this binds to the host cells and induces neutralizing antibodies. And you also have the neuraminidase protein, and this helps the virus to be released from the host cell. So there are 18 types of hemagglutinin and 11 types of neuraminidase. And so, as I mentioned, we use these to name the different viruses that are circulating, for example, H1N1 or H3N. Okay, so the data that I'm going to be presenting, so I'm going to focus mostly on influenza in South Africa. So the data that I'm going to be presenting, or the evidence that I'm going to be using, is mostly from these programs that I'm projecting here. And so the Viral Watch, again, so this is a long-standing program. It's been there since 1984. These are GPs who then enroll a patient who comes with an influenza-like illness. So if a patient has got a fever and a cough, they'll enroll this patient, and then they'll collect a sample. And then the state for flu, RSV, and SARS-CoV-2. And then, so this program, again, it's not a systematic program, right? So it's the GP, when they get that, the patient that they think meets the criteria, they collect the sample. And this is important, again, because then you see when I talk about the other programs, when I'm saying it's not systematic, as a result, this program actually collapsed in the first year of COVID, because then patients were not going to the GPs, or GPs were not enrolling cases. Okay. And then you've got outpatient influenza-like illness. So it's similar to the viral watch, but this is in public health clinics. And then we've got hospitalized cases. And so this is, again, in public hospitals and presently in 6 provinces. And Gauteng is one of the sites. So the Raimamosa and Helen Joseph, actually one of the sites that contributes to this program. And for this, we enroll all patients that that meet our criteria. For now, we're just saying is any lower respiratory tract infection, then they'll be enrolled. And we also have private consultations. So this is in private, and we get data from Netcare. And these are patients presenting, so we've got, initially we had hospitalized cases only, but now we've got clinics. So based on this, we can use the ICD codes to look at, at the respiratory codes that, for flu, for influenza or respiratory illnesses, and we can look at trends. Okay, so this is these are the case definitions that we use for syndromic surveillance. So these would be patients that are hospitalized. This, like, for example, patients that it's Raimamosa and Helen Joseph, and then this will be the patients that are influenza-like illnesses. This will be the clinics. Again, because we work in a setting where we've got different pathogens, important pathogens that we're interested in or that have got interventions. And so in that program, we've included testing for patients with suspected pertussis. So over and above an individual presenting with fever and cough or a physician diagnosed ALRI, we also include these patients that have got suspected pertussis. And so patients, so we've got dedicated teams that are in the wards, and so you've seen them again in the wards, and they're looking at the files and interviewing patients, and this is part of the program. And you get informed consent. Again, this is also a limitation of the study that, again, it's possibility of missing, we've got a possibility of missing very severe patients or critically ill patients or patients where there's no one to give consent. And therefore, our estimates may be underestimates because we would have missed severe cases. And they look at the records to see how the patient was managed, and they collect the specimens, right? And then the specimens, so it's a nasal swab or nasopharyngeal swab, and these are tested by, they come to NICD for testing, and they're tested by real-time PCR. So this is looking at the seasons from 2005 to 2019. The different colors reflect the predominant strain that was circulating that particular year. For an example, in 2019, the H3N2 was predominant, right? And then in 2018, we've had an H1N1, and again here H3N2, and this is an influenza B. Okay. And from here, you can see that our influenza, we're in temperate countries, so our influenza is highly seasonal, and the mean onset of the season is week 17. And so that will be about the 3rd week of April, and it usually peaks around week 23, which is the 1st week of June, and the mean duration is 12 to 25. Again, this is before we had COVID, right? Because during the first 2 years of COVID, things did change. Okay, and then this is showing you again data from 2016 to 2023. So this now is already including data during the COVID years. Okay, and then from here you can see that the peaks are more or less the same period, right? So this part here is all the years that are before COVID. And then when you see looking at 2020, and we had the flu season, right? Not a season, an outbreak that was in the Western Cape at the beginning of the year, but then during the rest of the 2020, there was no influenza. And then in 2021, we did see a peak that was sorry, 2021, a peak that was outside our season, like when we normally see the influenza season. Okay. And again, this is just showing you data from outpatients, and this is data from inpatients. And now we are in 2020, so in 2023, so already we started seeing, so that's the brownish color. We've already started seeing an increase. And again, for now, looking like we're seeing more cases in hospitalized than in outpatients, and it's normally the other way around. Okay. And then, yeah, and again, just also to mention that, again, if you're looking at 2022, right? So the season was quite long. I mean, besides, if you're not looking at the 2021, which was not a normal year, but in 2022, it continued for quite a bit than what we were expecting. Okay, again, so here I just wanted to show you that on a particular year, it is possible to have cross-circulation of the viruses. So this is 2022. And again, here you can see the biphasic peak. So this is outpatients, this is inpatients, and a biphasic peak first predominated by H1N1, and then later on with H3 and with influenza B. But then the H3N2 circulated throughout the season. Okay, all right, so on each year, so this is again data from 2022. So each year, besides defining this, so this is what we use to define the season. We look at outpatients, and then we've got an epidemic threshold, and we use data from previous years to set thresholds, and then we look at the detection rate during that year, and then able to tell whether the season is low, moderate, high, or very high. And so these are outpatients. So for transmission, we use that, and then for impact, we use this. So these are hospitalized cases. So in hospitalized cases, you can see most of the season last year was in the green, which is mostly a low. So it was it was a low impact season. So this is also important, in terms of your response. And so 2023, this is a global map. So different countries send they upload their results onto the WHO website. And then as you can see, so for here, I just wanted to show you that in the countries where already, some of the countries towards the end of 2022, right? They had high peaks, and then these high peaks were actually much higher than what we've seen previously. So again, I think it's important for us as we go into our flu season to be cognizant of the fact that it's possible that we may just see a lot of influenza than we've seen before. But again, with influenza, you can't tell beforehand. Okay, and then again, just also to show that, different countries, in terms of what's predominating at a particular time, it does vary. So this is what our 2023 is looking like. So these are outpatients, and already, for the past, I think, so this is data up until last week. For the past 3 weeks, we've had flu detection from our surveillance. And it's important for me to say that, our surveillance, it is sentinel surveillance, so it's not picking up all the influenza cases in the country, but it does give a good indication of what's going on. And again, in terms of hospitalized cases, again, it's been seeing, consistent detections of flu in patients admitted with respiratory illness. Okay, so in terms of transmission and impact, so again, as I mentioned earlier, using the old data to set thresholds and to look at so that we can tell when the season starts. So we use outpatient data to decide on the start of the season. So according to this, it has not started, but as you can see, week on week is going up again. So this is hospitalized cases. We are already on the hospitalized cases, this more increase than what we normally see, but again, I think it's still too early to say. So for the next few slides, I'm just going to go on talk about the risk groups for severe influenza illnesses and complications. And again, with the billion infections on an annual basis globally, and not everyone will have severe disease, but some groups will require hospitalization and some may even die. So this is looking at patients with influenza-associated acute lower respiratory tract infection. And so this was it from our data that we published a few years back. We used data that we had a site at Baragwanath Hospital. So we used we did incidents from that site because we use population from Soweto. I think what I wanted to show here again is to show you that the influenza-associated LRTI is high in children less than 5. But again, besides just being high in that, so if you look at all the different age groups, you can see that those who are HIV infected, they've got a higher risk of being hospitalized with influenza-associated illness compared to those who are not living with HIV. And again, once they are hospitalized, they've got 6 times greater odds of dying. So this is one of our risk groups that we should be targeting for prevention. Okay, and then again here, this is again looking at the estimated mean annual rates of influenza-associated severe respiratory illness. Again, just showing that you've got higher rates in those who are HIV infected. So if you're looking at HIV infected in all the rates, compared to those who are HIV. So these are HIV infected. And then what's important, we've got a good program for PMTC. So we've got patients that are children that are HIV uninfected, but they've been exposed. And so when you're looking at the risk, those are HIV exposed, uninfected, and HIV unexposed, uninfected. So the risk is much higher. Even though the risk is highest in those that are infected, but it is much higher in this group compared to this group that has not been HIV exposed. And then we also looked at mortality associated with seasonal and pandemic influenza amongst children. Again, just highlighting the fact that the incidence is really high in young children. And so if you look at these are children under 5. So if you're looking at the less than 1 and 1 to 4, the less than 1, so you've got higher numbers than you've got in the 1 to 4. But overall, the incidence is high. And again, when you're looking by HIV positive and HIV negative, again, your incidence. So comparing those two, the relative risk it's higher than those who are HIV infected. Again, I'm just talking about the HIV exposed uninfected. Again, just highlighting the fact that even though they don't do as worse, or they're not worse off as those who are HIV infected, but if you compare them to this group that is not that is unexposed, uninfected, so their risk is also quite is higher. And we also looked at children and to see what were the factors that were associated with severe acute respiratory illness amongst children less than 5. And again, you can see the underlying conditions came up, like asthma, malnutrition, and HIV. So those were, again, the risk factors for severe disease. And when you compare the very young to the older age groups, and you can see that these young ones, the very young patients have got a higher risk. Okay, so looking at over individuals that are older than 5, again, underlying conditions come up. And again, when you're looking at also things like looking nice, and again, HIV on its own is a standalone risk factor. So this is just summarizing the incidence results from BARA, so using all age groups again. If you look at this, so you get it's the highest in children, but then more in less than 1. But you do also get, though it comes down, but in that age group, then there's another sort of a peak in the young adults and also in the elderly. And then, so also pregnancy has been shown that it's individuals who are pregnant, influenza is a risk factor for severe disease. And this is just not only for the pregnancy, but also for the, not for the mom, but also for the child that they have preterm babies. And again, so looking here, pregnant women, seasonal influenza-associated mortality is higher compared to non-pregnant women. And again, when you're looking at HIV, so also it increases. And again, during the pandemic, so then this was when they were seeing more, severe illnesses amongst the pregnant women. So also looked at the factors, so this is also looking at TB. So here we're trying to see, co-infection with TB and influenza, again from this work, so that individuals who are co-infected with TB or who are testing positive for TB and looking what if they've got influenza, what happens. So there was increased risk of mortality. And also when you're looking at the other way around, like it's a person who's positive for influenza and when you test for TB, and the risk of mortality was also higher. So I think with all of that, I was just trying to highlight that even in our context, to say, what are the risk groups, and also we've got data to support again the motivation for vaccination. So when you're looking at the vaccination, I know now we're talking in terms of the of COVID. So the next slide, a few slides, I'm just going to show about vaccination. So when you're looking at this, so initially with our guidelines, we're saying, shouldn't give it at the same time, but now that has changed. We encourage clinicians, if they've got a patient that's eligible for both vaccines, to please give them during that, that consultation, so that to avoid our patients coming back for a different vaccine. And also this would then hopefully improve uptake. And for 2020, so with influenza, the vaccines change or most of the time they change every year. There has to be a meeting that's a decision to decide on what should go onto the vaccine formulations. So for our Southern Hemisphere vaccines, the meeting is in September, and this is our vaccine for this year. And so I've put the trivalent and quadrivalent. I know in public this year we only have trivalent, right? So which means we'll have the 2As and the 1B. We're not having Yamagata. And also just to say, the influenza Yamagata, the last time we saw it was in 2015. So the trivalent should be a good cover. And again, this contains 50 micrograms of each hemoglobin antigen, and this is a 8.5 dose. And again, vaccine wanes, but we just give it once a year, and we encourage it to be given before the flu season. And hopefully I've convinced, so with some of the risk groups that I've highlighted, I've convinced you that, which groups should be prioritized. And so based on the position paper, So these were the groups that were children, elderly, chronic medical conditions, and health workers. And then from so this is our guidelines. So this is so if you're looking at the risk groups, right, of the individuals and the risk groups for severe disease in our setting. So this is data from 2011. So it says there were 20 million cases, but we only provide about 1 million doses. And at the best of times, not all of those are being utilized. So I think this is one program that needs to be strengthened. Okay, and then so this is just listing the groups, and I've got health workers right at the top. And today I'm not going to ask how many of you have received your flu vaccine for 2023, but I hope it's quite a number of you. And because I think the reason why I've got health workers there is because not because there's increase of severe disease, but because you've got contact with patients, and some of the patients that you're dealing with are probably in those groups that are high risk of having severe influenza disease. And also we also want just for health workers to be protected, so that in the time when it's busy and all of that, then they're not sick and you're not out of work. And the elderly and all individuals with underlying conditions. So this is what the Department of Health is funding and paying for. However, everyone else who wants to have a flu vaccine should go and have a flu vaccine. But because of the the budget and the number of how much they have, so this is what they're prioritizing. Yeah. Okay, and then again, just again as a motivation for influenza vaccine, that it's been shown that it does reduce severe outcomes in hospitalized patients, and more benefit in those some individuals than others, and vaccinated adults are 52 to 79% less likely to die than those who are unvaccinated. So it does have benefit in preventing severe disease. Might not do so well in terms of infection, but it does prevent admission to ICU, and also the admission is reduced for those who are vaccinated. Okay, and then also, the paper from Marty and the team was just showing that these benefits when you're looking at it protects the infant and the mother. And then again, when you're looking at, again, it works well in HIV uninfected cohorts, but then in this group are HIV, are living with HIV, even though there was a signal in the mother, but that's the confidence interval too. Okay, and then its effectiveness, it varies from year to year, and again, so we managed to do this, and in some years, again, it depends on the match, whether how well the strain matches with what is circulating. But this is the type of work, so the things around 60%, but obviously it will depend on the match with the vaccine. Okay, and this is so from 21 and 2020, we are not able to do that, but 2022, and again, I just wanted to show here, so again, so we did have a VE, so any flu, it was about 60%, and H1N1, again, so it was 65 and 60%. And H3N2, then even though there was a signal, but confidence interval so wide. And B Victoria again, so that. And then treatment, currently, so treatment is not recommended for outpatients' mild illness, but we do advise that if for patients, especially the ones I was mentioning earlier, that have got a severe disease or at risk of severe disease, that to be good if when they were admitted to start, but also again, the recommendation is that if the patient is, presenting within 48 hours of onset of symptoms, because this is the time when it's, can benefit from giving antivirals. And I know that not all the hospitals have it, and it's really is not recommended for everyone. But by all means, individuals with high risk of severe complications, it is advisable. So in summary, so influenza is a public health important condition, and it's seasonal, and it causes seasonal and it's also pandemic burden, and with a high burden in low-income countries. And so with COVID, again, I didn't go into the presentation, but I think as clinicians, you know that, again, it's possible that, if when a patient in front of you presents the same, so is it COVID, is it flu? Again, in this setting, it might be good to do the test, because then also in terms of some of the management, you may need to know whether the person has got influenza, for example, if the decision is to add steroids or not. So transmission was interrupted in 2020. We saw an increased transmission out of season 2021. In 2022, the timing was similar to pre-COVID, but however, it went for a little bit longer. And vaccination, again, just to say that even though it's not 100% effective, it still prevents morbidity and mortality. And again, we don't have, we've got less doses available than groups at risk, groups for severe influenza disease. So if all the groups were applying on the Department of Health, we'll have a huge group that's not vaccinated. But however, even with that, we've got poor intake of vaccine. And again, just a reminder that co-administration of flu vaccine and COVID is safe. So we published as NICD, and on the NICD website, weekly reports from the surveillance. So if you wanted to know what's going on with influenza and SARS-CoV-2 or pertussis, you can find those on our website, and we do publish the guidelines on an annual basis. And again, just take this opportunity to thank everyone. I know a lot of you who contribute to the surveillance, whether you know it or you don't know, but you contribute quite a lot, and we really, really appreciate it. And with that, I'll take questions.
Great, thank you so much. I see Professor Bloomberg, you've got your hand up. Do you want to, hold on, I can ask you to unmute. There we are. You'll be able to unmute now.
Can you hear me? Thanks very much, Jeremy. It was an excellent talk, Sibongile. I'm really opening this question up to people in the medical wards. It's likely that we'll see an increase in COVID. What's possible will coincide with the influenza season. So how are we going to manage this in the wards? There's clinical overlap, there's even radiological overlap, but the treatment is quite different, and the markers are very specific, as I understand it, for COVID, for disease progression. But steroids are obviously quite important for progressive COVID. What are they going to do for influenza? Are we testing for both? I think in private they have, testing as a multiplex. How are we approaching this with the season coming up?
Yeah, it's a large problem. For my vote, I think we need these rapid tests available on the state hospital level, not the primary care clinic necessarily, because I think the role there is more complicated, but I do think at a hospital level, we need rapids. We've got obviously COVID rapids. We don't have flu rapids, which are part of the public health program, and that really should be, ideally flu, RSV and COVID would be the three to get right. I agree with you. It's actually a scenario we haven't had a lot of problem with before, because when we had COVID, we didn't have much flu. and vice versa. So this is the first year, it may be not so great. I see Lucille saying, hold on, let me make you co-host, then you can. You're saying rapid's not so sensitive, agreed. But I mean, in practice, it may be what, the best we can do. The PCRs take a long time, in terms of this. But I agree. I mean, it would be nice if we had PCRs on site. That would be good. I really
so
do
maybe we could do a COVID rapid, and if it's negative and it looks a bit more like flu, then manage it as such. Because, I don't think we have multiplex PCRs available in our public hospitals real time or quickly. I might be mistaken in some. So, progressive pneumonia in a diabetic or a pregnant woman or an older person, steroids, yes, no. What do you think, Jeremy? I'll put you in the spot.
I mean, I think WHO and most guidelines still recommend against steroids for flu, but on the basis of low quality evidence of observational evidence of harm. But so, there's the possibility that giving the steroids empirically in that scenario might do harm for flu. But I mean, there's obviously a lot of interest on that. But with COVID, clearly, it's the number one thing you can do.
Yeah, so maybe if there's a rapid positive COVID, then definitely go for it. If it's not, then, maybe investigate further and hang on. I don't know.
Definitely, it's hard. And again, I do think we need the diagnostics. I know that people have looked at it in the past and the cost effectiveness, etc. But I think COVID has changed that, exactly as you've said. I think, this is a more live issue in a way that it wasn't in previous years. If others want to chip in or type in or raise your hand, you're welcome to on that topic. But in the meantime, I'm just going to go to some of the other questions. Sibongile, there's a couple of questions on the first study with flu, which is an incredible study which you guys have done, and questions about HIV on it. So Lucy's was saying that as far as you can remember, the first study didn't show an increase in influenza-like illness in HIV-infected people who were stably on antiretroviral therapy. And there's a similar question also in the chat in a different thing. In other words, is this HIV increased risk with HIV? Is it really just the uncontrolled HIV, or is it everyone?
Yes, great question. So, okay, maybe just to say that first study is outpatient, so it's the community, so it's patients that are not hospitalized. So this one is only this cases, but yes. So for this analysis, we did not look at HIV suppression, or not whether patients were suppressed or not. But I would assume or suspect that then it's not the same in those who are, on treatment or fully suppressed. Because again, in other analysis, when you're looking at risk factors for example, SARS-CoV-2, so that there was an increase in those, it may be whether the patient was on treatment and suppressed and when
we're losing you a little bit, Sibongile.
Can you hear me? Okay, so
sorry, I can hear you now. Yeah.
Can you hear me? Okay, so no, I'm saying for this analysis, so we did not look at whether patients were suppressed or didn't look at viral loads and HIV counts and CD4 counts. But my suspicion is that I think in other work we've shown that if the patients are on treatment and they're suppressed, they do much better than those who are not. And again, I'm just using an example of looking at risk factors for severe COVID. That even though HIV infection was a risk factor for severe disease, those who were, were immunocompromised were at higher risk than those who were not immunocompromised.
Yeah, thank you. Yeah, that makes sense. One of the interesting things also with that first study, as you said, in outpatients, was just the degree of asymptomatic influenza and the amount at which that contributes to spread. I don't know if you wanted to comment on that too, because that was quite novel, or at least the extent of it was quite surprising, right, in the first study.
Okay, not the best person to talk on first, but yes, again, they saw a lot of, the rates of influenza in those patients who are asymptomatic were very high. So again, it also brings to the point that if we're only looking at patients who seek care or who are hospitalized, we really underestimating the burden of respiratory illnesses.
Yeah, no, I agreed. It was surprising. I think it was nearly half, I think, of them were asymptomatic. And then the eternal question, I know no one will know the answer. I mean, as in, you need a crystal ball. But this interesting thing with the Yamagata lineage, so that's, that's one of the influenza B lineages, one of the big two, which, as you said, hasn't been seen since, was it 2021? Was it, or 2020? But basically for about 2 years now, two to 3 years. I mean, do you think it'll ever pop up? What's your take on that? Or do you think it's gone? Do you think it's sort of eradicated?
Well, I don't know. It could be, I guess we have to wait and see. But yeah, so from our data set, the last time we saw it was 2018, but there are some countries also that are reporting that the last time we saw it is in 2017. But then, I mean, from previously, we've had other influenza viruses that we've not, like, for an example, the other H1N1, we've not seen it for a long time, but then
yeah,
I guess the short answer is we'll have to
yes, we'll have to wait and see. And then just the last question, just, I mean, well, not question really, but just to reiterate and to endorse your point about healthcare worker vaccines. It's the misconception is, from the healthcare workers, is that the vaccines primarily for your own benefit. It of course helps, but it's, as you rightly said, the big thing here is the healthcare workforce during winter. You will almost certainly, if you work in a hospital or clinic, be exposed to flu from some patient. And the idea is you need to stay healthy and intact so you can come back to work, and also not to spread it to the vulnerable patients, because the viral load peaks just around the time of symptoms or just before. So you'll be shedding flu before you know it. And it's really, really important to make sure that the healthcare worker, workforce takes this seriously. In many countries, you're not allowed to work as a doctor unless you've got proof of influenza vaccine for that year. That's not the case in South Africa, but it almost should be. So please, last thing, you can go and book from Dischem or Discovery or Dischem or Clicks or whatever, and you can get it paid for your medical aid. Really, really important. Okay, I think I'm just looking through the chat. Is there anything else? Just some of the things in rapids. Oh, sorry, one question in the chat. I don't know, sorry, it's a little bit off the, the local situation, but there was a question that asked me about the H5N1, the sort of avian influenza. That's eternally in the headlines for cropping up, but at the moment still relatively, well, it's an anxiety-provoking thing, but not much human-to-human transmission at all, right?
That's correct. Not a lot of human-to-human. There's no onward transmission, but also important maybe that I did not mention that, again, even in our borders, right, we currently have avian influenza. So I think as clinicians, even though it's not going to be common, but I guess we have to be on the alert. So we do, we do test if, especially in those groups where they're exposed in the farms, where there's been a lot of die-off, and again, also trying to do some surveillance on vet watch so that you can pick up avian influenzas. But it is, I think, I mean, even though it's not common, but then we always have to be, we should not forget about them.
Yeah, and sorry, we lost you for a second. Do the rapid and the PCR, do they detect H5N1?
So for ours, so the thing is, so whoever's testing will respect the influenza. That will be the starting point. And so if you send a sample from us, then we do typing and also doing sequencing. So if we're not able to subtype, and then it's again still good, sample with a high viral load, then we'll do additional tests.
Okay, no, great. Thank you.
And I think we'll be able to do further testing.
Perfect. No, thank you very much. Thanks. I don't think there's any other questions at the moment. So thank you very much, Sibongile. Really good to hear from you as always. And a real nice overview of the very topical topic of influenza. Professor Bloomberg's very good question about how to manage this in the COVID versus flu epidemic, when they're both around the same time, is, I think, a really good one. And I think we really need to all think about, how you would do it with resources you have. Like I said, my bet would be that I think we need to roll out diagnostics more broadly, but that may not be possible, certainly not possible in the short term in many of the state facilities. So it's really worthwhile keeping your ears to the ground and seeing what you might do.